Xin chào, xin chào. Thank you very much for having me here. I will speak a bit slowly. Of course, I can only speak English and not Vietnamese, but I would like to thank the organizer for having me here. So I've indeed my privilege and honor to be here with all of you to talk about and to share my experience on oral histamine, specifically belastin. We should all view, of course we're all ENT surgeons, I believe here, we're ENT specialists, but we should view allergy or allergic rhinitis as part of a bigger picture, okay? There's something called atopic march, okay? Where, of course, there are many different manifestations of allergy, of which allergic rhinitis is a significant portion. But this is not all about allergy of the nose, and when we treat allergic patients, we must also look at the other parts of the allergy that they may have. It's because of the nose problem they come to us, but it will be important for us, especially in children, because we're going to be seeing them as they grow. So it's important for us to pick up the different manifestations, yeah, all right? Sometimes they have skin problems, it may be food, and of course, allergic rhinitis. Although it's said here is after 3, I do have patients that are even before 3 years old, where I tested them for skin prick test and they're actually positive. I think given our climate, I think Malaysia and Vietnam, our climate are more or less the same. I think we should have the same allergy triggers. So atopic march is a progression of allergic conditions that have common genetic and environmental predisposing factor, and they share the Th2 responses, okay? The presence of one condition increases the risk for development of the other. That is why I told you it'd be good to look beyond our field, okay? To look into the skin issues, to look into the lung issues, because some of those issues may be even bigger than the nose issues, yeah? So classically, it begins with atopic dermatitis, eczema, and progresses to other IgE-mediated food allergy, asthma, and allergic rhinitis. So we are here, okay, but they may have other things that we may have to watch out for. Or sometimes it could be based on referrals from your other colleagues in other department, yeah? Okay, basically, given the time that I have, I would like to talk about some of this. I think the previous speaker has talked about allergic rhinitis, although I don't quite understand what's on the slide, but I can roughly guess, okay? And why is it urgent for us to treat? Okay, and what are so far the unmet needs? Okay, what are the needs that the needs that the patient want, but we as physicians may not able to provide that well. Okay, I think ARIA, the organization or the committee has set very clear guidelines, and I think on which a lot of framework, a lot of future guidelines are based on, okay? And of course now we have the new antihistamine, all right, if you can see some of the banners around and how I approach my patients here. Okay, I will not go to this that much because I think all of us will have a basic understanding, okay, especially those who have just graduated, yeah, you still have this very clear in your mind, okay? So we have the early response, we have the late response. So we have different symptoms, nasal congestion, hypersensitivity of the nose, they get itchy of the nose, they rub their nose, and of course nose block. So a lot of times they come at different stages, or some of them have been so chronic that they probably will have all. Or in some patients, they probably have only nose block and not much of sneezing, not much of running nose. So, but we know when you hear the history of the patient, you roughly have an idea what they have, right? And they come in findings, the skin problem, the swollen eyes. Okay, like I said, these allergens are very much similar between Malaysia and Vietnam, I believe, because we share the same climate, all right? Almost the same. And, this is based on a study about 10 years ago, where there's about 8.7% of respondents who has been diagnosed. And in fact, interestingly, in Vietnam and Malaysia, the numbers are there. Okay, so as you can see, I know Vietnam has a much bigger population than Malaysia, but by percentage, the allergic rhinitis proportion is also higher. Yeah, so definitely there's a lot of work for you all to do as well. Yeah. Okay, I won't too much into details of this. I think we all know. Yeah. Again, these are the predominant. I think are we running on battery? Okay. All right. All right. So these are the predominant symptoms in almost all population, and I think it's very important to have this in mind. Where we classified, this has been around for a long time. This classification, all right. Maybe the name, the English name at least, have changed. Yeah, intermittent, persistent. You have seasonal, perennial now. Again, the dividing point is if it's less. Sorry. How do I reverse that? Can I reverse one slide? Okay. Okay, sorry. So if I think it's very important to have this in mind because we also want to assess the social impact or the impact on their studies or their work life. Yeah. So less than 4 is considered intermittent. More than 4 is considered persistent. Yeah. Then you assess them in terms of their workplace, their studies, the different impacts that they have. So not just the number of days that you have, but how they are affected. Even sleep is something that we should consider. So a lot of times we only see what is on the surface, okay? But behind that, there's a lot more that we don't understand, we don't see until we investigate further. So there are a lot of long-term proven complications. Many a times in my practice, the parents for children, yeah, the parents will say, oh, this is very normal to have this. So when they come with runny nose, sneezing, to the parents, it's normal. But I always correct them, I tell them, it is common, but it does not make it normal, okay? Just like it's common to have thieves around, but it's not normal, okay? So there must be a distinction between what is normal and what is not. So I think for us, we have to educate them. It is very common. In fact, there are patients who come after 1 year. There are patients who come with the nose is fully blocked, but to them, it is normal, okay? But we must always correct them to say that it's common, but it's not normal. So there is the role of the doctors to improve and to correct them. So I will talk about some of the side effects as to why it's urgent for us to treat. And also, it's not just running nose. There are other things that if we don't treat, things can happen. All right, in terms of infection, in terms of, sorry, pointer is not working very well, sorry. There's no, do you see any laser? Okay, in terms of infection, the anomalies, other mouth breathing effects, obstructive sleep apnea, sleep issues, social issues, and of course the long term of bronchial asthma risk is, they must understand. So when we put a camera in, now this scope is so easy to use. It's, I'm sure all are trained to use scope, to handle scopes. So these are things that we can see. The adenoid tissue can be enlarged, the tonsils in the throat can be enlarged as well, besides the turbinate, inferior turbinate. So all this will lead on to a lot of possible complications, in terms of the ear infection, otitis media, adenoid inflammation, hypertrophy. I do have patients that have, basically zero airway at the back of the nose because the adenoids are so large. So you get sinusitis complication, tonsillitis, and now with more tests that we can do for the eustachian tube, we can also diagnose them early that they have eustachian tube dysfunction before they even develop full-blown otitis media with effusion. Of course, like in many things in life, a lot of things come in different shapes or sizes, so you have the different noses here. But the primary objective of the nose is actually to breathe. Okay, not to look nice. Of course, now with social media, everybody wants to have a nice nose, rhinoplasties, and so on. But the primary objective of the nose is to breathe. That's why in babies, when they're first born, it's very important for them to breathe. Otherwise, they can actually die because they need to breathe through the nose before we learn how to breathe through the mouth. So there goes the problem. As we grow older, when the nose gets blocked, we have learned to breathe through the mouth. But now, the ENT in my country, we are engaging more with the dental people because we are aware, now we are more sensitive to what long-term nose block can bring to the facial features of the patient. So there's something called adenoid facies where the mid-face is elongated because of chronic mouth breathing. Then there are certain features that they have black circles under the eye. You have some lines under the eyes as well. And patients who do this all the time will have what we call the allergic salute crease. And this is, I'm trying my best to give you the whole picture of what can happen if chronic long-term blockage, it will lead on to a lot of other things as well. Can I have a laser pointer? So they get chronic persistent, and because of the interaction of the nose and the mouth, because of the chronic interaction between nose and the mouth, they are not able to breathe better. So with that, there's lack of tongue stimulation into the palate, and with that, there's going to be dental anomalies. So all this takes years to happen. Therefore, patients who think their nose block is normal have actually lived with this condition and allow all these changes to happen. Right? So don't be surprised by the time you come, by the time the patient is seen, they can have all these dental problems. You can see the high arch palate on the other side, okay, and a lot of dental crowding as well. Okay, so it doesn't look nice because of the oral breathing. So it doesn't look nice, but the problem is not only they don't look nice, they can have other problems as well. They can have deviated nasal septum, they can have, all right, sorry. Okay, there are also other effects of chronic mouth breathing, yeah? They have more likelihood of all this gingivitis, plaque, dental issues as well, right? Although we as ENTs don't need to fix that, but you know the dentists will have a lot more work to do. All these are because of chronic nose breathers, and there's a lot of changes in the oral flora as well, which in the long term doesn't augur well for the patient. And you can see some papers who look at the different flora of the nose, of the mouth, there's change because of the chronic mouth breather. And in this case, there's adenoid blockage that causes the mouth breathing. Okay, important issue is as well, a lot of times we may also think snoring is normal. Well, once in a while if you snore it's fine, but if you're snoring every night, it's not normal. Because this happened to my own son as well, you know. At 6 years old, he was diagnosed with enlarged adenoid, enlarged tonsils. So although he did not have allergic rhinitis symptoms. Yeah, so we must also change the parents' mindset in that snoring is not normal, yeah. There must be problems, either the adenoids are enlarged, inferior turbinate, or the tonsils. So we must, we don't have to do a sleep study for children, but we can look out or advise the parents to look out for these symptoms, headache, they feel very tired the next day, or they're hyperactive. And I do have patients with growth failure as well, as young as 11 months old. Yeah, so I've done patients who are under 1 year old, who have chronic enlargement of the adenoid that leads on to growth failure besides the ear problem. Okay, I will not go through this, but there are whole lot of papers out there, yeah, in the English language on all these effects of sleep by allergic rhinitis. I think we must also be aware of asthma. All right, this is not something we can see immediately within 1 or 2 years, but there are enough studies. This is one of a few important landmark papers that says that, you know, untreated allergic rhinitis leads on to asthma in a major portion of them. The risk is about 3 times more to develop asthma. And here in this this paper, you're looking at about 1,008 cohorts, yeah. So, and the follow-up is for 23 years in the US. So this is a long follow-up. So out of this data, they've actually managed to collate some other conclusions as well. Besides the fact that AR, okay, can lead on to the risk of, well, they call it hay fever in this picture, in this paper, but it's actually bronchial asthma. Yeah. So this cohort also later on was studied as well, where even rhinitis increased the risk of development of asthma among atopic and even non-atopic patients. All right. So definitely in both atopic and non-atopic subject with rhinitis, they are definitely at a higher risk to develop bronchial asthma. Again, okay, I will not go into this. You can see some of the mechanisms to explain the influence of nasal dysfunction on the lower airway. Of course, nowadays we talk about the concept of one airway disease where the lung and the nose sort of interact with one another. AR is also associated with bronchial hyperresponsiveness. It's easier to mention one airway disease because the nose, if not controlled well, will affect asthma, will lead on to asthmatic attack. And from the cohort that we mentioned just now, they have also looked at the question, does treatment make a difference? So yes, indeed it does. So improvement of asthma was associated with resolution of AR symptoms, and a worsening of asthma was associated with persistence of AR symptoms. So it's also important because I'm sure in your practice there are a lot of patients with asthma who have allergic rhinitis, and all the other way around, allergic rhinitis who have asthma. Okay, the general number is about 30% of AR patients who have asthma, about 80% minimum of asthmatic patients will have AR. So these two are closely related. So be good friends with your respiratory physicians. You will need to refer to one another. Yeah. Of course, thankfully, we have gone past the era of COVID. Yeah. Imagine during COVID, if someone were to sneeze next to you, I think you probably run away and start doing all the tests on yourself. Okay. So definitely all the sneezing, all the running nose, it's very troublesome. Yeah, even for myself, if I have a lot of running nose, I will not do. I mean, if I'm not well, I don't have allergic rhinitis. If I'm not well, my nose is dripping away. I don't think I can do major surgeries where the nose will be dripping away. So definitely, there's also an issue with quality of life. Yeah. So maybe among the children, it's not so obvious, but for adults, definitely this is a very important factor. Well, viruses will come and go. So influenza, in my country, influenza right now, for the last 1 or 2 months have been on the rise as well, especially in December, right? So, of course, we've come a long way in terms of treatment, diagnosis, in terms of advocates of certain treatment. So the basic rules still hold true where the intermittent and persistent stratification is being done. And we have come, area started since 2001, we've come a long way. So if you look closely here, for mild, the options are your oral, I will call it OAH, oral antihistamine, all right, intranasal H1 blocker. I'm not sure if you have intranasal H1 blocker here, or leukotriene antagonist. So as you stratify them, all right, so you will go towards this end where you're going to see the intranasal steroids coming in as well. All right, and for those who are keen on cure, we can talk about immunotherapy. Okay, this is a magnification of what we saw earlier. So definitely oral H1 blocker matters a lot in the treatment. All right, from this 2010 revision at that time, they definitely recommend the newer generation of OAH that do not cause sedation. The first generation does a lot and do not interact with the cytochrome P450, yeah? Because interaction with this will cause a lot more unpredictable metabolism of the drug in terms of dosage, in terms of interaction with the drugs. Okay, for some of the more persistent ones, they talk about intranasal corticosteroid sprays. Yeah. So if you, again, have this cross-section, I think I saw this chart earlier, it's safe to say that we can start off as a first line or second generation of non-sedating antihistamine across the board. Okay, so you can start this off as a first line of treatment, no harm doing that. And definitely we have also come a long way, all right, from the time of the dinosaurs to what we have right now. So we have different versions of the oral antihistamine. Of course, as we go along, we always like to improve, everybody will always want the fastest, the highest, the strongest. I think the same goes to your handphone, the same goes to your medication. So patient gets more demanding, okay? They want, maybe I should add, in the Asian society, they also want it the cheapest, okay? So that's very true in my culture, in my practice as well. They want the best, the fastest. all the good things at a very cheap price. Okay, so what are the unmet needs? I think financially definitely is one of thing that we need to look at. And if you look at across the board, so definitely in adult and in children, my favorite antihistamine to go to is belastin. Okay, this is some of the summary that you can look at, where they look at H1 receptor, right, metabolism. This is the time to achieve maximum, the half-life, maximum effects, half-life, and the clinical indication, including urticaria, whether you need to adjust the dose, and whatever clinical relevant interaction, alcohol contraindication, and there are some area properties, I think there's 15 properties that they actually try to fulfill. So you can see definitely belastin rank very high in terms of receptor selectivity here. Okay, so that will make the drug, well, the drug affinity will make it effective. I think you saw this chart just now. So this is how all stack up against each other. So they are looking at the brain H1 receptor occupancy. So the more H1 brain receptors being occupied, the higher chance as well that the patient will get more sedation or more sedative effect. Yeah, we want to be able to function normally, right, on this medication. There's some new guidelines as well. You can check this out as well. This is pretty comprehensive. And just now, the IFAR paper was also very comprehensive. You can look through that. There's about 50, 70 pages all in. Yeah, so a lot of reading to be done. This is also, as area evolves, there are new guidelines that have come up. This is, I think, during the time of COVID as well, where they look at visual analog score. Yeah, you can Google that. A visual analog score basically is a collection of symptom score. They ask the patient to grade themselves, and they even have an app for it. Yeah, you can download to your handphone, and with that, because it's during the COVID era, so it's some form of teleconferencing or a remote management of patients. And I think you saw this chart just now earlier. So this area guideline has gone through different revisions. And first line, as you can see here, oral antihistamines 1. Okay, they've started to move on to intracortical steroid with azelastine. So you can see the VAS is a visual analog score. So how they use visual analog score to help the patient to certify them and to start them on different types of treatment. Okay, so this is a much improved version of from the initial ARIA guidelines since 2001. So basically, we want our antihistamines to be non-sedating, free of anticholinergic effect, to be well tolerated, safe, effective, and of course, in our Asian society, I must say, cheap as well. Yeah, okay. So this is how things will stack up in comparison. I'm not sure what's available here locally, but definitely we have all this back in Malaysia. So what has been different with belastin is that now, with their new improved formulation, is come up with something that the others have not come up yet, which is the oral dispersible tablet. So if you fulfill the criteria for seasonal allergic rhinitis, perennial allergic rhinitis, or chronic CIU, definitely belastin is one of the options to think of. So what has made this interesting is that it's like sweet. You just put on your tongue and it will dissolve. Okay, you don't have to carry those bottles around. Chances of breaking the bottle, glass bottle, and chances of avoiding possible dosing errors. Because for those 6 and above, right, to 11 years old, you can use this ODT provided their age is more than, provided their weight is more than 20 kilos. Yeah. You just put on the tongue, you maybe swallow it. After that, yeah, it's easier to swallow than conventional tablets because it's a standard dose for those age that 6 to 11 age group. So the no risk of wrong calculation or wrong dosing of the drug. And also because it's in the tablet form, in this packaging, it makes it easy. You don't need refrigeration. So it's easy to bring around. So it's a very user-friendly kind of formulation they've come up with. So as you can see here, it's only once a day. All right, so what was recommended is actually patients 6 to 11 years old with body weight of at least 20 kilos. Right, so it's like your M&M chocolate, yeah? You put in your mouth, melts in your mouth, not in your hands, okay? So you put this inside the mouth, on the tongue, you wait for it to dissolve, and you just swallow. So it's pretty simple, okay? So you can put it in water, but again, here, after the research that they've done, they've advised that to take it 1 hour before or 2 hours after food, because otherwise, the bioavailability of the medication can be reduced. Yeah, not a major harm, but just that you want what's worth of your money, right? So you want to get the maximum benefits. So this is what they have recommended. So it's pretty easy to use. Yeah. So in my approach of the patients with AR, yeah, so it's always important to confirm. I mean, you have a lot of guidelines, but at the end of the day, after you practice for a while, you do have your certain techniques of doing things. Because AR also many times overlap with upper respiratory tract infection, and if you're looking at vasomotor rhinitis, especially for the older population, so it's very important to know whether you're actually treating AR, you know, before you start any kind of treatment. And I think I talked about the atopic mush just now, the atopic dermatitis, urticaria, asthma, and not to forget AR's own complication that we have to manage: adenoids, ear, yeah, sinusitis. We try our best to follow the AR guidelines. In my country, when the word steroid is being mentioned, a lot of times the parents will, you know, think twice, 3 times before agreeing to any kind of usage of steroids. As we know, steroids are being used inhalational for the nose, for the lungs. So I think, again, we have to talk a lot to the parents to cool them down, to tell them steroid is not as bad as you think. There are rules of steroid. Be aware of side effects, especially with the older antihistamine, but for the newer ones, it's indeed very, very safe. Yeah. And also, some kids are difficult, they don't have to take medicine, okay? So the best you can do is probably give them something like this once a day, pop in the mouth. That's easy rather than syrup. But again, I'm quite sure there are some other children who will probably don't want to take anything at all, or sometimes nasal spray, they don't like it. So again, there's a lot of changes you have to make along the way to ensure compliance. Not to mention, it depends on where you practice, whether whatever is discussed here, you have it, you don't have it, or if it's too much to buy, to pay for. And in terms of follow-up, okay, you also have to assess them, how to follow up the patients. You cannot just see them once and say, you know, closed case. You do have to ensure they come back for follow-up, yeah, whether through apps or communicating with the patient online. Of course, nowadays, we prefer to see the patient, you know, in person rather than through online. Yeah, so basically this summarizes how I manage my allergic rhinitis patient. Given the new medication that we have, very effective, very good, but there are still some basic principles that I will follow. These are mine. So in conclusion, so a lot of times we only see them, you know, as a tip of the iceberg, but behind it there are a lot of stories. Yeah, so that's why online conversation or online consultation may not be the best. We still have to see the patients for whatever reasons I mentioned just now. Yeah, so it's always more than meets the eye. It's always easier to treat early than when you come in with all the other complications. Of course, you need your respiratory physicians, you need a dermatologist to help you as well. I think it's very important to educate them. Now, I will fail in my duty if I don't tell you that we have to educate the patients. For example, I just mentioned steroids. Yeah, what is normal? What is common? A common thing doesn't make it normal. All right. So compliance is very important. All right. It's no single magic pill. You take one and that's it. All done for the rest of the years. No, it's ongoing kind of thing. Where again, so oral antihistamine as a first line is definitely a good option, and if you can, choose the second generation, because this will ensure good results and good outcome for the patient. Thank you very much.